It's time to enhance the relationship between expertise and impact, between knowledge and application. Welcome to a journey of discovery and empowerment. Welcome to All Physicians Lead, the Forbes Books podcast that highlights the critical leadership role that all practicing physicians take on every day. Here's Dr. Leon Morse.
We're pleased to have as our guest today Dr. Rachel Thompson. She is a nationally recognized physician leader with over 2 decades of experience building high-performing medical teams and advancing hospitalist medicine. She currently serves as the Chief Medical Officer at Core Clinical Partners and is the immediate past president of the Society of Hospital Medicine. Dr. Thompson, welcome to the podcast.
Thank you. I appreciate you having me. I think it'll be an exciting conversation.
Well, it's very, very exciting for me. We're all about physician leadership here at All Physicians Lead, and certainly everything that you've done, I think, will provide some valuable insights to our listeners. So we appreciate having you on.
Well, thank you.
So one of the things that we like to start with is just an encapsulation of your journey. Why did you go into medicine in the first place? Where'd you grow up? How'd your career sort itself out? Those are big decisions for folks, and we'd like to hear your story a bit.
Thank you, Leon. Please call me Rachel. Oh my gosh, how far back do we want to go? But
Oh, kindergarten, usually.
oh
Most
no.
people start there. No, just
Oh
kidding.
gosh, no. I honestly, I think I always had a sense of if I look back on it, I guess the word would be compassion for others, and that seemed to be, maybe my drive, and when I was little, I would find animals to save and bring them
Oh,
home, so my family was frequently trying to figure out what do we do with all these dogs and cats that Rachel keeps bringing home. So, as I grew up and thought, well, science is kind of fun, and, I maybe I'll be a veterinarian, but something switched over in high school years, and I think that was conscience kinda coming in and thinking, well, being a veterinarian would be, at that point, it was not everybody had the resources to have animals and to care for them. And so I kind of started to switch my brain a little bit more to wanting to be and maybe that was the beginning of my interest in public health, was really that idea of, like, working with and for people, and that would be something that I could do more broadly and reach more, of the population. So I set my mind on medicine. Now I thought that was probably the end of the conversation. I was like, "Oh, hey, yeah, I'll be a doctor."
okay,
Yes,
done. Yeah.
exactly, done. But then I suppose that was just the beginning. I studied, biology and fell in love with and accidentally got a second, degree while I was an undergraduate in psychology because I just did enough coursework. It was senior year. It was like, "Oh, one more course and you get a double major." I found that world of the human brain very interesting, and, then, went on into medical school. I had been a bit of a basic science researcher through college and then my research that I did in immunology, and then in medical school, I was spending my time sort of probably moving into that space more direct the patient care, and the people that were, influencing me at the time were people who were, very good at the bedside, people who could really connect with other humans, and that pulled me pretty deeply into that space. I also come from a family of educators, so it's not surprising I started thinking like, "Okay, the only place you can be a doctor is in education," so started straight out in academic medicine, and that was the piece between looking at, okay, well, after you do your I fell into internal medicine, really liked the sort of the sleuthing and the figuring things out and putting things together in the whole picture, and then you could also add in the caring for the people, and found myself at it in my 3rd year of residency at the beginning, back at our big county hospital in Seattle, Washington, and, someone said, "Hey, do you wanna, start a service for us this next year?" Where we're starting to think we need internists in the hospital. And so, we had 2 people that year join who were the first 2. I was the 3rd person in the hospital, but given a different domain. of developing internal medicine in a hospital-based setting, which eventually became the hospital medicine movement, really.
That's right.
Yeah.
Yeah, which is wonderful, I'll tell you from a surgeon's point of view. We'll get into that
Well,
later, but
that's where I started, was in working with the complexity of patients had grown so much that part of what was asked of me was to help in this level 1 trauma county hospital with the surgical patients. And then interestingly, going back to my roots in psychology too there, we have a very large population of psychiatric patients at the hospital
Mhm.
with, some pretty severe, uh, conditions, disease, status, there. So I was the internist for the non-medicine, units at the time. Yeah. So that was that's a fast nutshell, but
Yeah, that's fascinating. But, like you said, we sort of think back, and in some ways it seems random, but then in other ways, when I look at my career, for instance, and perhaps as well yours, it makes so much sense when you
right.
walk it through. It said, that was meant to happen." So,
Right,
it
right.
sounds like there was a lot of meant to happen
Right, right,
that happened in your case, so
right.
Um, one of the things that we talk about here quite a bit is that every physician is influencing behavior to achieve a desired result, i.e., leading all the time.
Mhm.
Um, but at some point, you decided to take up more formal leadership roles within organizations. Can you think back to what inspired you to take your leadership to that next level, and what were the factors that assisted you or hindered you if you along the way?
Right, right. Well, I think, it's a really interesting question to be thinking about where was there a moment or was there a set of things? Because I definitely was in the era where it wasn't part of our training, right? It
Yeah,
wasn't part of our thought, and that thought that all physicians are leaders, or really all humans can and are leaders in the sense that we can
that's right.
influence others. And so I do find that, you know, we didn't have that language, that training, and walking into a place where I needed to develop new service lines and from day one, be able to put together projects that were successful or not, but still keep going.
Right, you can't always win, right?
Right,
Yeah,
exactly. So I think that I in a way, the invitation to be in that role in the hospital really gave me that opportunity to learn quickly and to practice. And I say one of my core parts of me may be that compassion that brought the animals home. Another is my curiosity. I'm annoyingly curious. And so when I learned I needed to, I was going to have this opportunity to do this new role, I felt like I need to understand what's it like. So I sought people out to understand what is it. What do you do to be the internist for the surgeons? What do you do to be the internist for the psychiatric patients? And how do I develop the and have add the greatest value to this care that's happening. So through that curiosity, learning about being able to bring things together to make sense for processes was became very an early piece of my training in my first job. At the same time, I think when I realized leadership might be a slightly there was sort of that gradual piece maybe in that one that I'm just doing these things, but the moment where I might have been, woken up a bit, or maybe somebody would say someone slapped you across the face and said, "Oh, this is now you need to be," was when, it's a funny story because it relates to being an educator in medicine as well as being in the perioperative space. But we had within the University of Washington system, one of the world-renowned, diabetologists who had a lot of strong and rightful opinions of how we should care for patients in the hospital before we had publications saying we should try to keep sugars under control perioperatively. And so my residents, we had multiple hospitals, and my residents were like, "Oh, hey, look at this really cool form that we have for insulin ordering over at the university hospital. Dr. Hirsch helped us make this," and I'm like, "Oh, that's really cool." So of course I'm thinking, "Okay, great," but I don't know yet enough to know how you actually implement these things in a hospital setting. And I can remember because I looked at the form and it said all the hospitals on it. I was like, great, let's use it. And then, a few days later, someone's like, Rachel, I hear you and your residents are using a form that hasn't gone through forms committee yet. I'm like, oh no.
Oh, no, forms committee.
Oh no. I'm like, what's forms committee? And so, learning by mistake that I had not done it in the right way, um, for me, that got 2 things going. I was like, "Oh my goodness, what is this?" And the young person in that the young part of me says, "Oh my gosh, what kind of rigmarole is this?" But then the practicalist in me says, "Okay, well, let's get it through the forms committee then." So, you rushed too fast and you learned you just gotta slow down. But I think that was an interesting moment for me. It's such a mundane example, but just where I realized there's this world that needs to know what you're doing, right? And you need it's that piece of those committees. As much as we all may want to roll our eyes at how many committees, how many steps there are to get something done, they're there for hopefully a reason. And in the most positive spaces, they're really contributing to the ability to communicate something, right?
Right.
And so I'm always operating in my little world of like, this is the right thing to do. We're going to do it. Not even thinking outside of myself that, gosh, there's a whole bunch of people who need to be trained to this form as well. Because that was back on the triplicate days when you actually had one form go down to pharmacy, one form went into the MR, and one form like stayed with the order set. So, yeah.
Yeah, that's very amazing insight, right? I mean, when we're brought up through undergrad, medical school, residency, we're fairly autonomous actors,
Right.
right?
Exactly.
And, you know, way back in the day when I was starting, not only was it not encouraged to necessarily consider all these broad stakeholders
Yeah.
throughout the healthcare system, but they almost treated like the enemy. They're trying to prevent you from
Right.
taking care, which is clearly not true. We get older, we mature, we see why all these systems are built. But that revelation that you talked about, that switch flips and you say, wow, there's a lot of really smart, talented, dedicated people that make sure that when I say knife, it gets put in my hand, and the steps
You're
that
right.
wind that back
Yeah.
for that to happen, from like initial procurement to funding to
Right.
purchasing to biomed to
Right.
sterilization to the technician to knife,
Right.
is a lot of people.
It is, and it's in a way, as we talk a bit about that too, it's like that was maybe my first, experience of saying, "Okay, change management in the way we think of it in quality in medicine," and we do when with my teams, I'm working a lot with the principles of the Cotter's model of change, right? And so really thinking that I didn't realize that I needed to take something through a change management process, and so I ended up doing what we all do, which is, making a mess of it. And so I had to go back and actually take it through the process. So it was a really good education from a slip up or a lack of awareness, probably a lack of education of myself too.
Well, the positive reframe on that is that, you ignited a spark
Yeah.
with this that then, flourished
Well,
in your
it's
organization and came
fascinating
to
to
pass
say
for,
that.
better quality, right?
It was because what happened after that was that it aligned me. It was again these things that happen for a reason. You say that it seems like, oh, if you think of it, it seems random. It's a small little thing. But after that, I ended up working with a number of people in nursing, with the endocrinologist who had been wanting to try to get this on the books for quite a long time. And because
Oh, wow.
now it led us to actually at the time get funding for a glycemic control team, which was then like a few years later that was the reference team in our state, and we had some of the coolest programs. It was I didn't lead it. Endocrinology, nursing, led it. I was on it as the hospitalist, but it was one of these things that happened out of the collaborations that came out of this little thing. So this tiny little thing ended up becoming like that spark
That's awesome.
for really good work that later on, led to being able to help other health systems. And you see all those good things coming out of just being like, being collaborative in that space and being able to
Yeah.
build something together. So,
Yeah, the teams are pretty impressive when you get to know all those other players, right?
yeah, absolutely.
Because they could work in other industries too. I mean, these are all
Yeah,
smart, talented people. They
yeah.
they don't have to be slogging through the complex maze of healthcare.
Right, right.
Right?
Exactly.
You could probably have a nice 9 to 5 job in a, bank or an, IT security company with the intellect and talent and
Mhm.
effort that you put in and, maybe even get paid more than you do as a floor nurse or a
Mhm.
clinic administrator.
Mhm.
But they're dedicated to patient care, like we are.
Right.
So
Right. Right.
it's neat stuff. So you talked about compassion and curiosity, fundamental constructs that are important for leadership, obviously. Thinking back, is there an event or, more than one perhaps that you experienced that changed how you lead today? You sort of, gave
Mhm.
one example. Any others where you think,
Mhm.
wow, that really changed my leadership
Mhm.
style
Yeah.
for the better, and why?
Yeah. I think it's really been I'd say that might have been the moment where I realized it, but it has been a process. So it's probably been so many things over all of this time. Now that's over 20 years ago when that happened. That that event happened with with using the forms from the wrong hospital. So it's really hard to pick out one thing, but I do think when I think about how I as 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 well-intentioned as I was, and as much as I was thinking about, how do I do this well? How can I plan for this? What do I how do I design this thing, this new role that I was coming into? I was also very reactive, right, at that time, and so and maybe that's a bit of I mean, this is an interesting thought. I don't we'll chase it for a moment, see where it goes, but if that idea that we are sort of taught to be autonomous, you're kinda coming out of your training thinking, "Okay, I've gotta go, and I gotta figure this out," as opposed to slowing it down and saying, "Let's bring everything in and take that, that slower, more methodical approach." And so, it's probably been over time, all of the events have shifted me to be into that slower thinking space, and let's be more deliberate without and recognizing when it's time to be deliberate and when it's time to be more fast acting. Um, so I'd say if I looked back at that time, I was much more reactive. And although we still have to be very reactive in medicine, in leadership today, I find myself pushing myself and others to try to spend more time in the proactive space and really trying to design for us to be successful rather we'd find ourselves every day in all the different spaces I've been in every day there's plenty of fires that keep us going. We talk about it. They're fires. We're just firefighting. Today I just spent firefighting. I didn't get anything done because I was just putting out fires. Putting out fires is getting things
That
done.
to-do list didn't change.
If we didn't
If anything, it got bigger while I was putting out fires, right?
yeah, and I didn't advance our vision today, maybe. I didn't get a
Yeah.
step forward towards where I'd like to take this, project, or I didn't get my project time. I just ended up having to deal with this, that, the other thing. And so trying to I think it can put us into a space where that's what we find ourselves maybe subconsciously feeling as we just are firefighters and we have to very deliberately say, okay, I am going to take the time, make the time to be able to be thinking ahead, to be able to build for tomorrow and not just react to today or yesterday.
Yeah. So sure, at least take part of the time to be a fire prevention officer and not a
Exactly. That's a
firefighter,
great
right?
way of saying it. Right.
So,
Yeah.
well, it's interesting, so let's pull on that thread, and as you were describing that, I thought, well, why what gets us there, right? What's the cause and effect that says, I'm a firefighter in the hospital, right? But if you go back to we talk about medical school drinking out of the fire hose, right? There's so much information you need to digest, right? And then you get into training and you're overwhelmed and
Yeah.
there's plenty of sick people that you've got to take care of, you got to round, you got to make decisions, you got to implement those decisions, follow them. And we don't build in, well, let's take an hour and a half each day and just sit and deliberate. I mean, we have grand rounds and we have teaching rounds and things like that, but still that's even those are little snippets of fires that,
Mhm.
you might present 20 cases in an
Mhm.
hour
Mhm.
and try to get through them and get
Mhm.
through your day and then
Right.
finish your charting. And
Right.
so we don't necessarily build in or as a culture say, stop and think as much. So as you were saying that, I thought, well, that's how we're raised,
There.
in this profession is we just go, 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 go,
Right.
to fix all of the patients that we need to fix or prevent them from getting sick, as
Right.
best we can.
Right.
It's a fascinating concept.
Well, and it seems like that's if you live in that space enough, or if it's enough of your day, which it is for us in medicine, it's it can almost become like then that's my natural response. That's my first go-to. It's like, "Okay, I'm gonna put out the
Right.
fire." Rather than, saying, "Oh, wait a minute. That one can burn, and then I can be working on this instead because that one just, I let me give myself the space for tomorrow, so that I can be thinking about how do we create something, you know, today we're extremely focused in the acute care spaces on our patients, which is what we should be focused on. Are they what is their experience? What is it like to be in a hospital overnight? Is it restful? Is it
Mhm.
comfortable? It gets down to the idea that, oh wait, oh, we're caring for humans. We're caring for people. And it's actually this idea that it's maybe been there all along, but this when you even get down to the little thin little garment we give somebody to lay in a sterile plasticky bed with,
Aren't they nice?
so dehumanizing, right?
Yeah.
So how do we create, that and that's not something that was, necessarily taught in medical school either, is like, how do we create a comfortable space for people so they can heal, really, right? And so when we think about all of that, you can't build that when you're so focused on your 20th patient coming in through the ER that you're acutely issue that you've got
Yeah.
to deal with, or you're doing back-to-back surgeries all day and it's high intensity, or you're in the clinic and it's that and we've been driven towards volumes and acuities, and even in my few decades of a career, I've seen that acuity change in the hospital, which blows my mind to think about what was it like 100 years ago when we first started having hospitals in the United States. Like I mean, that must have been very different. Or even in the 1940s, 1950s, when
Yeah.
basically you went in the hospital for a month and you got penicillin, for a month or something. And that's what we could do for you. And we can maybe at that time in my mind, I think, wow, we probably did care for people, hopefully a good bit more because there were no computers to have to be typing into all day. There's only 1 or 2 meds that got passed. So,
Yeah.
all these really cumbersome things for physicians, for nurses, were very different, So, yeah, how would we and then at the same time, we went through all this, fun, exciting development of technology and development of the ability to do more for people, whether it's pharmaceutical or whether it's surgical or whether it's just the technological. It also created a lot of busy work for us in medicine on all disciplines, and that's taken up a whole bunch of our time. And yet, I feel like wouldn't it be cool if we're on this edge of where that busy work's about to go away again? And maybe that's the eternal optimism. Some pours out, Rachel, don't count on it. That's always gonna be there, but we're playing with things like, AI documentation
Mhm.
for folks in medicine. They can spend, and hospitalists can spend 4 hours a day, 6 hours a day just typing or
That's right.
or even dictating. And if you take that away from it, it gets us back to why we're here, for me, a big part of doing that type of a project is to see people light up and be like, "Oh, I'm re-engaging now as a my purpose is to help others, and I'm here as a clinician to support the care of others or to focus on that care, and this other thing is just happening in the background." So, for me, those things are exciting, and maybe that's why I I'm I like the position that I'm in, where I
Yeah.
get to now facilitate finding ways to make things work well for clinicians, so it benefits the patients. So,
Yeah, you talk about restoring your joy in medicine, right? If you
right.
can
Yeah, thank you.
sit down, lean back, face the patient,
Right.
um, ask the questions, have a conversation, not feel the time pressure, allow them to articulate what they want instead of feeling like, okay, I need to ask the next question and move along because I'm going to spend 15 minutes with you and then I'm going to spend 25 minutes putting it into the
Right.
EMR,
Right. Right.
uh,
Right.
in addition to all of the other administrative overhead.
Right.
And that creates stress. When you tell folks why or ask, why do you think you've burned out? Why do you feel so much stress? Almost never do you hear, I just can't stand talking to patients.
Right.
That's not in the top 10.
Right. Right.
Um,
Right.
I don't like doing physical exams.
Right.
That's not what you hear. What you hear is all of this extraneous stuff. And like you said, I think we may be on a cusp. I mean, I certainly feel it in my clinical practice that we're becoming more efficient with the way the EMR is working. Dictation is really caught up. I mean, I can dictate, herniated nucleus pulposus, and it doesn't even flinch anymore. That
Right.
wasn't
This is
first few iterations of Dragon. You couldn't figure that out, and you have to
right.
retype everything.
Right.
So,
Right. Right.
when the next step comes along and something puts in an entire clinic note, and then I just briefly look at it and edit it,
Yep.
that'll be a huge step.
Yeah, yeah. And I've been able to both at the public health district that I was working in, that's when it was first being making its footprint, and now there are a number of companies in that space that I've been able to watch and very curious about because for me that is you said it well. It's putting the joy back into medicine. And in the public health district where I was, we were able to use a local company that was starting that kind of product, and then it ended up now it's Microsoft's product, of course, because it's in the Northwest. So it went into Dubai. I say I contracted with a small company. We just had our discussions with a small company. We signed with Nuance, and then we went live with Microsoft. So it was all in the like, accelerated phase where we were luckily and fun on the front end of that. But my favorite thing, there were two things that my clinician said who were using it, and my favorite two things were, I feel like a doctor again. I
Right.
feel like I can, and the what behind that was the ability to make eye contact and just spend the entire encounter communicating with the person that was
Yeah, it's beautiful, right?
and I know, I was like, "Oh, this is amazing." And then, the other was actually a really insightful comment from another clinician who had said what she really appreciated about it was how well it captures the patient's story. And it's because it's
Mhm.
taking the patient's words directly, and I think in our go, 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 go mentality, we know we've got 20 minutes, 25 minutes, maybe 30 if we're lucky, if we're talking about a clinic visit. But you've got a certain set amount of time, and you've got of that time, you're also supposed to get the documentation done, or else it's going to be done tonight after after you've already
Yeah.
put 12
Put the
hours
kids
into
to
your day.
bed and yeah,
Yeah.
exactly.
And so you're trying to get just shave things down. And now, that thought is that, oh, wait a minute, I'm going to walk out and I'm going to look at this. It's like going to make a few quick changes. And so it is I think that's what gives me a lot of excitement for the future for that. There's a lot of what it might also be able to do, but even just seeing it in that setting, and now we've brought it in for our emergency medicine spaces, at working on like I said, there's a lot of different companies doing this. So I've been able to work with a couple, but being able to just take that burden off of the clinicians has been totally worth it because the clinicians is going to make the clinician happier and it's going to make the connection stronger with the person who is the patient.
Yeah, yeah. Well, and we talk about restoring joy and reducing burnout, and there is some writing about this, but to further elucidate on that, this second and third order effects that a happy doctor has on
Yes.
the team,
Yes.
the patient, the family.
Hmm.
We talk a lot at All Physicians Lead about the fact that, and this isn't about doctors being all that or the boss
Yeah.
or anything like that, but
Yeah.
you have influence,
Right.
you have impact.
Right.
And, if in a clinic or the OR or the ER, the ICU, the doctor's having a bad day, that influences the team dynamic not only in terms of psychological safety and people feeling free to speak up, but just the
Yep.
the feel, right?
Right,
Everybody's like,
right, right,
"Ooh,
right.
ooh, oh no." And so, if you do something like you just described and, 100,000 doctors just come in bouncing into work going, "What? This is great. I
Right,
love being a doctor again." Imagine the second and third order effects on the clinic
right,
as a whole, the
right.
patient experience, and ultimately, I believe the patient's enthusiasm to implement the plan that we put together. If they walk into a clinic and it's completely dysfunctional and they don't have a good experience, they're like, I'm not going to listen to those clowns. But if
Exactly.
everybody's happy and excited and enthusiastic, you walk out saying, well, they really know what they're doing. I'm going to take these medications and
Right.
I'm going to try to lose weight and stop smoking and all that.
Right, 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 right. No, I think you're absolutely it that second, third order that you're talking about and taking it all the way to the reaction and the behavior, how we influence behavior. And I mean, maybe that gets back to that piece too about, all physicians lead because you are, whether you're it's setting up in that inside in that clinic space or where we're having influence on our peers or the patient too. I mean, we do not have the patient is not in our circle of control, right? They are in our circle of influence, we hope. But that also depends on what you're talking about, which is, what's the feeling? That I feel like if I'm the patient, do I feel like I can trust? Do I feel like they care? Do I feel like they're organized enough to know what they're doing? And if those things aren't, then I might be well outside of your area of influence. That's for sure.
That's right, yeah, and if, you picture the doctor who's stressed and, comes walking in and most of the time is facing a computer screen and then says, "Here, do this, that, and the other."
Mhm. Yeah.
There's no sense of caring,
Right. Right.
we made very little eye contact, and,
Right.
this person really doesn't care, and so the likelihood that, you know, you're gonna do all that varies. I'm not saying that it goes
Certainly.
away, but I can't imagine that increases
Mhm.
the
Right.
likelihood
Right.
that someone's going to follow through with a designed plan.
Certainly. Certainly. Yeah.
So, what's it like building something with a bunch of surgeons? I can poke fun at them because I am one,
Love
but,
it.
you walk into this scenario and you're like,
Yeah.
"Oh
Yeah.
my gosh, nobody's done this before,"
Yeah.
and I'm outside my tribe, I
Right.
mean, we're
Right.
doctors, yes,
Yeah.
but, we have tribes within doctorhood.
Oh, absolutely.
Um, what was that like, and what leadership lessons did you learn? How did you work your way through that?
Thinking back to that, I think, probably again, naively, I didn't understand tribes quite as much. Residency can train you on that a little bit, I think. But I think at the same time, it didn't, that segmentation, um, wasn't super strong. Maybe it was because of the role too that I was to be the builder of the bridge, and so by curiosity, I needed to understand what's on the other side of the bridge, and I think that that's so important for us to do in all aspects of life, definitely within medicine at work. But if we can start by understanding what's their day like, what is the reason that somebody has that reaction, whether it's what's their understanding, what's their fear, and then to be able to say, okay, the reason why we're setting this up is because, they want the best care for their patients, and we can help, right? And so a lot of that was maybe early translation of, some of the tensions may have been why, why can't they just do it? Why can't the surgeons just take care of their own, you know? Well, one of the more eye-opening things was, this is another. It's funny. It's gonna be another glycemic control piece, but one of the surgeons I worked with said, and who was at this point, we had a very strong working relationship. Chair of neurosurgery said to me, he said, some of these medications that are coming out, I did not train on. And it's simply that I feel like I can trust that you understand these, and that's your role. That's where you work. And it was, at that point we had been working really well hand in hand. And when we designed the co-management service with neurosurgery, we actually built it with a weekly educational session, and we alternated neurosurgical topic, internal medicine topic. And it ended up
Oh,
being
fascinating.
that all of the ICU nurses loved to come to this. So we kept it open. It was just anyone can come. So residents could come, our residents, so both neurosurgical residents, internal medicine residents could come to that. Um, I learned very terrifying things about looking at imaging of brains that I would, and bleeds in brains and things that gave me nightmares. Like, is my 8-year-old going to end up with a brain bleed? Because that's
Yeah.
one of the examples we were looking at. Things that, in internal medicine, we try to avoid these scary, scary things like that. We like other scary things, but
Oh, yes, you do.
yeah, but, and then we'd flip it and do a topic that was from a medicine angle, and we just went back and forth, and it was very well attended and collegial in that setting. And so I think that was a really neat example of, let's uh, we are caring for people, right? And it doesn't matter what that person's current issue today is. There's a reason for us to collaborate and work on behalf of that person, on behalf of that human together. And so it was always being able to bring it back down to that. The tensions around, oh, what's whose domain, you work through those if you're focused, everyone's focused on the same outcome, which is, let's get the best possible care for this person.
Yeah. Yeah, you mentioned these new I can't spell half of the new drugs throughout, let alone know what their side effects are in dosing,
Right,
so
right.
I'm very sympathetic, and, one of the things when I talk to my, medicine, and now I'm almost exclusively pediatric, so pediatric colleagues is, give yourself credit for all the things that I don't. I can't keep up, r really with everything that's coming out in pediatric neurosurgery. None of us can totally,
Mhm.
some are better than others, let alone
Right,
all the new things somewhere else. So, on the surface, you'd think, well, why doesn't he just read his own EKGs? And
right,
really, he can't,
right, right,
write an order for this
right,
med.
right,
Um, and, conversely, I would never think to say, hey, before this patient comes down, my colleague on the medicine side of the house, why don't you mark where to make the incision,
right,
right? So some things that
right,
seem very
right,
basic to me,
right,
no comprehension whatsoever,
right.
and vice versa. I would have no idea even where to start. It would take me, 2 hours of Google Scholar to say, what do I even look at in terms of a med list for this diagnosis?
And it's not the right thing for everybody to have to know everything, right? It is,
Yeah.
and maybe that's the team training of being a kid growing up playing soccer too, is that, you know, you can't play all positions and you shouldn't play all positions. I mean, people need to work together to make something happen. And it becomes very clear, if we have those things, we can make something quite much more I don't know, maybe it's much more symphonic or whatever the analogy might
That's
be,
right.
but
Yeah.
together. And so by saying, yes, this is your expertise, this is your expertise, this is my expertise, and how do we put that together? And even beyond just physicians, there's an expertise. And I loved working out at County because one of the greatest set of experts I got to work with were our amazing nurses. And so working with the nurses that I worked with, we all would, when we got to a code together, we were all like, okay, good. We've got our crew. And so,
Yeah.
and it was always, and we knew we trusted each other's expertise in that space. And it was really that ability that we can't see ranks and we can't see hierarchy. We need to see what is everybody's strength, and let's use that strength to the greater good, right? And let people be as autonomous as that is, but let's not put them in the wrong seat. Let's get everybody together.
Yeah, and, that brings to mind something that I emphasize. I knowingly, expected that the title of the book, the organization All Physicians Lead, might be off-putting to fellow professionals in the healthcare
Mhm.
space, and very explicit about the fact that it doesn't mean that the doctor is the boss. All this means is that yes, they're influencing behavior to achieve a desired result. But then you think, well, actually, doctors aren't the only clinicians that do that. So maybe it's all providers lead. So APL, can say that. But doctors and, other providers are not the only ones. So whether you're an administrator, a nurse, a technician, all professionals lead. But as you said earlier, and I appreciated you saying it, all people lead.
Mhm.
If we're awake and there's another person in the room,
Right.
or in this case on Zoom together, right? Then all people are influencing behavior
Mhm.
all the time.
Right. Right.
And, not recognizing that we do it, not
Yeah.
appreciating the fact that we have influence and impact is the gap
Right.
that, we're trying to
Yeah.
get people to think about, um, and have some self-awareness,
Yes. Yeah.
which then leads to self-management.
Right. Right.
Earlier you were talking about sort of your default style, and we all have one.
Mhm.
But if you don't know that a default style exists,
Right.
you're not aware of what your default style is, and then you're not managing the right style
Mhm.
for the right
Mhm.
situation
Mhm. Mhm. Mhm.
because you don't even know these things exist. Then, we've got a gap there of education and training that, I wanna start in medical schools and residencies so that physicians in particular, and the same concepts and curriculum can be spread across the entire system for all professionals, will be able to say, "Wow, I recognize that my actions matter, that it
Right.
affects the team and the patient and the
Right.
family,
Right.
and I wanna be better at that," and there
Right.
are tools and techniques to do just that.
Right. Right. Well, and I think uh two thoughts from there is one is all physicians lead is it's important because I don't think that because of the way that we're trained and because of the way maybe our brains are wired, so there's some pre-selection bias too on that one. But if we haven't thought of that idea that it's leading, it's important that as a group of professionals, as physicians, that we recognize that influence we have on others. And so in a way we do need to say, yes, physicians, you are leaders whether or not you have a title. People are watching you. They are looking to you, and how you act is going to influence if somebody else, probably if five other people, you come in storming into the ED as the doc for the day, and you come in crabby, and now there are multiple people who are now having a bad day too, right? And it's sort of that we need to be able to recognize that because there's if we're not aware of that awareness that to that basic level that we have that influence on others, we need to at least start with that.
Yeah. And it doesn't mean you're all that or you're the most important person, but just it
Well,
is. It
and it's
exists,
very
you know?
human. It's very human. I mean, you could
Yeah.
have it could be the nurse that comes in to the ER that's really
That's right.
having a bad day and could really kind of
And impacts
sell
the
for everyone
team
else. Yeah.
for that,
Yeah.
for sure.
And then I think the other piece you were talking about that was really like struck the thought for me is that ability to be self-aware and self-regulate and that knowledge that there are different default styles and there are different ways to be and then and then let's take it that next level to say as a human, definitely as a leader, but as a human, how great is it when we can learn to flex ourselves? As some have said, and I'd say I probably learned this most strongly from my mother was, the only thing you control is you. And, it was probably said when I was complaining about, "Oh, this isn't fair and that's not fair." Well, life's not fair. The only thing you control is what you do from it.
That's right.
But it is true. It's like we can learn to flex and be the more flexible we can be in our approach to things without sacrificing our beliefs and our values. We have to have strong moral and ethical direction. But at the same time, the more we can flex and we can welcome others, the better that's going to build that trust, build the team, build the ability to provide what we need. And honestly, we're going to be happier too than when we're hitting a wall. So that's I really like that idea of moving into that space where we're recognizing, oh, somebody needs me to be a little softer today. And someone needs me to like slow down and say, what's going on? What's going on in your life? I notice you seem a little bit quieter, whatever it is, you know, taking care of each other.
Yeah. Yeah, so when, one of the examples I use is if it's at 10 o'clock at night and I'm in the operating room and a child is hemorrhaging, just struck by a car, and I my default mode is pace setting, and so I am in that mode, everyone is on board with that, nobody's objecting to it. But if I carry that style into clinic the next day, it might work, but probably affiliative would be a little better, and
Mhm,
then if I'm
mhm,
in the C-suite the next day
mhm,
as president of the medical group and
mhm.
try to go into the pace setting mode, I'm gonna get kicked out of my ear and should be much more
Right,
democratic,
right, right,
right?
right,
Um,
right.
and so if the neurosurgeon is just the bull in the china shop in every single environment, that's a stereotype, right? Uh, and they're there for a reason, but recognizing that that's probably not the best requires some thought, education, training, just like you said, ability to flex for the appropriate leadership style
Right.
is super important.
Well, and you have the knowledge and the language because you've studied this, you've written about it, like to be able to label those different uh roles that you can take on the different days and the roles you should take on different days. Because there's nothing wrong with being the pace setter. We want that. We want you to be the pace setter in that space because that's a kid's life, right? And we think about that too in emergency medicine, even hospital medicine, when it's like the ICU or that's that high acuity moment. You've got to be reactive. You got to be driving things. But the better you can then evolve and flex to another situation or the needs of another person around you, um, the more effective you are and in your role as a physician.
Yeah. Yeah.
Yeah.
Well, speaking of being effective, how's the CMO at Core gig? How did you dive into that? What's it been like? What are your priorities now? Tell us about where you're at.
Thank you for asking. I've been with CORE for a year and a half officially as the CMO. I actually met the founder, Boykin Robinson, through a colleague probably 5-ish years ago, and he had started the company just with one emergency room, with the thought that he had been a part of a company in that where I grew up through academics. He had spent 18 years in this physician services companies, and he had seen what, as you get really big, some of the challenges. And he had this moment to think of it. Well, what if we design a company that can be very locally focused, but have all the skills that you get when you're a big company, have all the people that, so I had met him 5 years ago. We had a really fun, interesting conversation, actually, interestingly, about the psychology of being in medicine. And 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 then intermittently had talked to some of his medical directors to help coach them here or there over the years in between. And then post, COVID came, and in acute care realm, things, especially emergency medicine, things really slowed down from a provider standpoint. People weren't going to the ER. There
That's
wasn't as
right.
much of a
Yeah, yeah, yeah.
need for emergency medicine physicians or clinicians. And so after COVID, however, his company, his approach really did take off. It's all organic growth. It's not a big private equity or debt backed anything. It's just growing by word of mouth. And so 23 hit, and with that, all of that growth, he was ready to expand and needed more physician leadership and invited me to the team. So it has been a fantastic opportunity for me in my life to be able to be in a place where we have about 650 clinicians. In 2024, we had a million visits across the country. And it gets back to that thinking of like, how can we design things so it goes so well for people, clinicians, and therefore then patients, and that second and third order influence that you're speaking as well. So no way are we there, but that is the journey we are on, is really figuring out how do we put in the right processes to get the best outcomes for patients, whether we're talking about hitting the sepsis targets, because we know if we use the sepsis bundle, we're going to reduce sepsis mortality, or whether it's about what is the patient's experience as they walk into this waiting room, or as they get rolled into this hospital room. What are the ways that we can work to influence improvements in patient experience? And so for me, it's a giant playground to get to say, let's go partner with hospitals, figure out, work with them to figure out how do we make things better there. And it's a bit of an implementation science. It's a lot of an implementation science because you always have a lot of ideas of how it could go, but you never know how it's going to work in a specific environment without partnering with the folks who know that environment. And so uh, I enjoy it so much to be able to go somewhere, listen, learn, meet people, understand what works well, what are the pain points, what are their current efforts, and then where can we bring and add and or bring people together. So I'm using skills that date back to the forms committee of saying let's bring these multidisciplinary groups together in these different environments and let's design it together. Let's say how are we going to work on getting patients to be able to be seen fast enough in an emergency room that they aren't leaving? Or how do we work on the workflows and the communication in a hospital such that patients aren't lingering there for 2, 3, 5 extra days just because our communication systems aren't strong?
Oh, wow. Yeah.
And so it in that way, it is a playground, for me in that I mean, that's not the right term, but it's just so much fun to be able to work with people on making things better for people.
Yeah, it's not immoral, illegal, or fattening to be having fun at work. I just wanted to throw that out. You were like, well, maybe I shouldn't say it's this much
I know, I
fun,
know.
you know, but don't hate on that. It's definitely great that you're making a difference
Yeah,
and enjoying it, right? Those are
thank you.
mutually exclusive. We're kind of raised to think that pain is a good thing, right, in our profession,
So true, so true, so true.
but you
And then I
if you
won't
have
don't
fun.
let me make it look too pretty. There's plenty of pain. Just it's just like,
We'll give you credit for that.
I'm gonna be the one smiling and be like, "We can do this."
There you go, there you go. Without spilling any proprietary beans, but, an example, a practical example of something that, you've gone in, your organization has found this, and
Certainly.
you did that,
Right,
and
right. Yeah.
XYZ happened.
Right, right. Well, I could do, several, but, probably since maybe I'll start with the hospital medicine one of the hospital medicine ones because I'm a story. But it also touches on this public health. So we didn't talk about it, but mid-career crisis for me 10 years ago, a little over 10 years ago, I was like, "Oh, well, this is good, but I want to, I've got this, I'm getting this doctor thing down. What else? My curiosity got me. What else do I want to know?" And so I got my MPH at the University of
Right.
Washington while on faculty. I was working and doing the extended MPH where you could keep working and do that.
Yeah, that's
But that
always
public
fun,
health
right? Yeah,
side of
let's
me,
add additional work.
right. So going back to my example, it's really it gets because it's a hospitalist one, it gets because it's a public health for me issue, and it's about access to care. So a health system that we worked with, we were hired in to help because the program wasn't strong in helping support a number of things for the hospital. They're looking for a partner. So we come in as a partners. And actually, this was one of our more challenging starts because the prior group um, had a non-compete and we couldn't keep anyone. Right. So we had to
Cool.
hire 90 clinicians at our start. And so we've had to find 90 people, but that was also kind of the beauty of it because now we're starting something fresh and a new culture, and we can set a whole you can kind of it was maybe that's why this all worked. So as we went into this health system, two larger hospitals, several smaller hospitals in the communities around, it's you can see that us being in there working on processes around how do we even staff this? How where do we put our clinicians? So we did some geographic rounding. We worked on how the communications between our clinicians and nursing and therapy and social work and case management. And we call these multidisciplinary rounds in the hospital setting or IDRs or IDTs, whatever the term of the hospital is. But how do we set those up so that we're getting good, efficient communications on a regular basis? And at that hospital, you just look at the graphs as we got in there, the hospital would be happy because the length of stay for patients was dropping, just time
Wow.
month over month, just because of what we were putting into place. Um, to the point at which, and this is the public health part of me, um, they were seeing open beds that they had never seen before. And then what had happened is, as we were working through all of this, it was that they had a backlog of patients that needed to get to this tertiary quaternary care center that could just not get in. And if you look at the math of who was getting in before and how many people were being were unable to transfer in because of the lack of beds, today, 450 people every month more get into that hospital than before we came on board. And that means
Wow.
we're able to serve at that level of care, closer to home, 450 people a month. And that by itself
Yeah,
is so worth it.
that's
So worth it.
incredible. Yeah, 50,000 people a year,
Yeah.
if
I'm
I
good
did
with
the
math.
math right on that.
Exactly. There you go. Yeah.
Wow, that's yeah.
A lot of
So
lives touched. A lot of lives.
kudos to you. Couple minutes left. Parting shots, advice to young physicians about leadership, going into these roles. What excites you? Um, Anything you want.
I I think there's a lot that we all have to offer, and maybe this gets to the all physicians lead, but yeah, for folks going into the field, being in leadership may not always seem appealing, and there is sort of a recoil from it right now, and these things go up and down, but it is what we're doing, and the more we can dive in and participate in leading where we go, the better. In the how and how do we make ourselves good leaders side of things, I'd say it just goes right back to that: be curious, lead with curiosity. And if you genuinely leading with curiosity, you will get there. And so please, first and foremost, please be willing to lead, and then once you make that decision, please, be curious.
That's awesome. Great wrap up. Rachel, thanks so much again for joining us here at All Physicians Lead. I appreciate you taking the time in your super busy schedule. You're influencing care all around the country, and so taking some of your precious time to spend with our listeners
I appreciate
is
what
really
you're
great.
doing. I appreciate you putting this shining a light on it for all of us, so thank you.
Well, like you said, I don't want to say it's too much fun because then people won't, click out. There's got to be some pain somewhere, but it is a lot of fun. It is a lot of fun. So, all right, thanks very much.
Well, take care, man. Thank you.
This has been All Physicians Lead. We can all be better leaders, and our teammates and patients will be the beneficiaries. Go to allphysicianslead.com to unlock your potential, sharpen your impact, and elevate your journey. All Physicians Lead with Dr. Leon Morse is a production of Forbes Books.